Hi everyone, I am Pieter-Jan CUYLE. I am a gastroenterologist and a digestive oncologist in the hospitals of Bonheiden and Leuven in Belgium. As part of the ESDO LearningBytes initiative, I will give you a brief update on malignant bowel obstruction and mainly focusing on the setting of advanced stage cancer. I will take you through the scope of the problem, then which diagnostic steps to take, the process of decision making, and our therapeutic options. Although many definitions are used for malignant bowel obstruction, we mainly use it to significate that bowel obstruction is present due to cancer or its treatment. It occurs in 3 to 15% of all advanced stage cancers, and it has a particularly high incidence in advanced gynecological and GI cancers. Depending on the location of the obstruction, patient usually experience nausea, vomiting, colic-like abdominal pain, and especially in distal obstructions, abdominal distension, and often there's a lack of flatus and stool passage. It is very important to know that every obstruction can result in bowel wall ischemia, which is called strangulation, and might cause a bowel perforation. These complications are often fatal if not treated surgically in the acute setting, although it has to be mentioned that strangulation tends to occur less frequent in the setting of malignant bowel obstruction, although bowel perforation is seen from time to time. Furthermore, there's a profound effect on quality of life when malignant bowel obstruction occurs, and it has a devastating impact on prognosis because of the resulting malnutrition with cachexy and sarcopenia. Management is often very difficult in advanced stage setting because of the deteriorating mobility and function of the patient, so they often have a poor performance status. There's a lack of further anti-cancer treatment options. There is a high morbidity and mortality associated with palliative surgery in this setting, and there's a lack of high-level scientific guidance or evidence for this problem. When suspecting a malignant bowel obstruction, the gold standard is still a contrast-enhanced CT scan of abdomen and pelvis. It will deliver us information on the location and the cause of the obstruction, whether or not it's a partial or a complete blockage of the gastrointestinal tract, and whether or not it's located on one level or multiple levels of the GI tract, and then whether or not these worrisome complications like ischemia or perforation are present. Small bowel obstruction is more frequent than large bowel obstruction, although we have to be aware that in 1/5 of cases, obstruction will synchronously involve both large and small bowel. Obviously, it's important to consider the cause of the obstruction. In malignant bowel obstruction, it's cancer related. It can be an extrinsic bowel compression, for example, by a peritoneal malignant mass or adhesions from previous anti-cancer surgery. It might be an endoluminal obstruction caused by a GI polyp or a GI tumor, or even radiotherapy-induced fibrosis, usually of the small intestine. It can also be a functional obstruction caused by tumor invasion of an enteric nerve plexus, or it can be drug-induced, like for example opioids, or be caused by a paraneoplastic phenomenon. Although it is important to consider that even in the setting of advanced cancer, not all obstructions are cancer related, so these patients can also develop, for example, an incarcerated inguinal hernia. As been said, decision making in the setting of malignant bowel obstruction is often very difficult and needs to be undertaken in the context of a multidisciplinary team. In this team, we need to consider the obstruction-related factors, of which I've talked about in the previous slide, and we have to put them next to cancer-related factors and patient-related factors. Cancer-related factors, obviously the malignant disease extension is important, the general prognosis of this patient is important, and whether or not he or she has remaining treatment, anti-cancer treatment options. And then obviously patient-related factors are important, patient characteristics like the age, the comorbidity, and the performance status. and quite obviously the patient preference. So we have to consider all these factors and discuss them in an ideally experienced multidisciplinary team consisting of abdominal surgeons, oncologists, gastroenterologists, preferably one with therapeutic endoscopy experience, radiologist, radiotherapist, and obviously a palliative care specialist. And then hopefully we will develop an individualized treatment goal for this patient. As mentioned, the management of malignant bowel obstruction is based on low-level scientific evidence, often retrospective or single-center data, small randomized trials not showing a lot of benefit of certain interventions or even conflicting data. What we generally do is initial resuscitative measures when suspecting bowel obstruction. We put the patient on nihil peros, we give fluid and electrolyte replacement therapy. We perform the diagnostic CT scan and then discuss the patient in a multidisciplinary team, basically deciding on whether or not the patient is a surgical candidate. If not, we go for medical management. If surgery is considered, it is important to look at the timing and the type of surgery. Timing, we have to take into regard that a lot of this surgery has to be undertaken in an often very hostile abdominal environment because of prior abdominal surgery, prior abdominal radiation, or just the disease extent itself. And it is important to know that about 1/3 of malignant bowel obstructions can resolve spontaneously. However, above 70% of those patients will relapse eventually. But this knowledge allows for an initial conservative management of surgical candidates for at least 2 or 3 days, and if no resolution of the bowel obstruction is seen, we can move to surgery. The surgeon can evaluate different types of surgery. We can do a bowel resection with reanastomosis. We can do a diverting stoma placement, although an ileostomy should be avoided because of the risk of high output ileostomy, or the surgeon can go for an internal bypass surgery. If the patient is not a surgical candidate, we have to go for medical management, which is mainly consisting of bowel decompression, pharmacological interventions. We have to consider nutritional support in this setting, and therapeutic endoscopy. Bowel decompression in the acute setting means placement of a nasogastric or nasointestinal suction tube. If bowel obstruction tends to be chronic, a percutaneous venting gastrostomy needs to be considered. It can be placed endoscopically or radiologically guided, and it can be a lot more elegant for the patient than the maintenance of a nasogastric tube. Pharmacological interventions are based on these principles. Usually the combination of antiemetics is given along with anti-secretory drugs, anti-inflammatory drugs. Obviously analgesics need to be considered in this setting, and also antibiotics are to be considered. You can use any antiemetic you want, although you have to be careful with prokinetics, which are contraindicated in the presence of a complete obstruction because they can aggravate the colic-like pain for the patients. We often give PPI, proton pump inhibitors, or anticholinergics as an initial medication for obstruction. You have to consider somatostatin analogs because they are very potent anti-secretory drugs for the GI tract. Often corticosteroids are associated because of their anti-inflammatory characteristics, and they are also antiemetic. And you have to consider antibiotics because of the risk of bacterial translocation, especially in immune suppressed patients. For exact doses and intervals of medication, I can refer you to this review article below. Nutritional support needs to be considered, although parenteral nutrition is controversial, especially in the setting of terminally ill patients, where there is an advice not to use it. And then Last but not least, we have to consider therapeutic endoscopy for all lesions within reach of the endoscope, except for the distal rectum, which cannot be stented because of obvious resulting symptoms like tenesmus or soiling. Self-expandable metal stents are used for this, either to reinstitute the natural luminal passage by placing the stent over through the stenosis, or by performing an endoscopic bypass procedure, for example, an endoscopic ultrasound guided gastroenterostomy. For this, uncovered, partially covered, or fully covered stents are available, which I will not discuss in detail. With placement of self-expandable metal stents, you have to consider the problems of stent reocclusion because of tumor progression, stent migration, or a local regional perforation. And for this, there is some concern with the use of anti-VEGF targeted agents after placement of a self-expandable metal stent, which might be associated with an increased risk of perforation. So to conclude the take-home messages, malignant bowel obstruction is prevalent in advanced stage cancer and is associated with a profound impact on quality of life and prognosis of patients. Contrast enhanced CT of abdomen and pelvis remains the gold standard in diagnostic and therapeutic assessment of this problem, and therapeutic decision-making in malignant bowel obstruction is often difficult and needs to be undertaken in the context of an experienced multidisciplinary team. Thank you.